Thanks, Rick. The integrated clinical and research care is, of course, the core of our mission. But what's really exciting about this plan is that special ecosystem that only Nationwide Children's brings to the table. We have unique programs in health equity and population health, genomics, and behavioral health that no other children's hospital can bring to the table in the same manner that we do. It's essentially our secret sauce. And I'm here to interview the leaders in those areas so that we can understand how we are now leading best outcomes across the country. We're going to start with health equity and population health. If I can get the next slide. This is actually a slide that we used in our last strategic plan, but it is so relevant and so important that we continue to carry it forward. Health equity is Nationwide Children's approach to how we are going to eliminate inequities for children everywhere. And what we have here are the kids on the left. They're getting equal treatment. They all have a stool of the same size. But what you can see is our poor little girl in the center still can't see over the counter. Health equity is getting the resources that every child needs in the manner that they need them. So for the child on the left, they don't need a stool at all, and our little girl in the middle, she needs a higher stool. And when we talk about health equity, that is what we mean. We have with us today Dr. Dina Chisholm, who is the director of the Center for Child Health Equity and Outcomes Research. Dina, how does the health equity and population health work support our core clinical mission? And where will we go with population health work over the next 5 years?
Well, you know, the key part is the mission, which is being a leader in best outcomes. And we can't be the leader in best outcomes unless we're the leader in best outcomes for everyone. We have to be certain that the opportunity for best outcomes is equal for all children, regardless of their race, regardless of their zip code, regardless of their community, regardless of their sexual orientation and gender identity. We want to be able to have a system that meets the needs of every child when they need them to be met. And so we build that into our approach of thinking about kids not just when they come in the door for a specific procedure, but when they are living their lives.
So
thinking
out
about
in
out in the community,
Okay.
thinking about the whole child. So our approach to population health and health equity is going to include increasing our Partners for Kids geographic scale and breadth. As you know, Partners for Kids is the only pediatric accountable care organization inside a children's hospital. It gives us a great opportunity to not just think about the care side, but to also think about the health side, because healthier children make a more efficient ACO, which has money then to do more work that makes kids even healthier.
And it's a lot of kids too. Over
Lots of kids, over 400,000,
Okay.
exactly. Continuing to expand access for underserved populations, not just in our hospitals, but in lots of settings, meeting kids where they are. Thinking about how we expand our programs and policies that are addressing social determinants of health, because we know it's not just health care. We know a lot goes into determining the health of children and families. And then importantly, particularly for me as a researcher, is knowing whether what we're doing is making a difference. Studying what's going on, what's working, and how we can do it better. A lot of this is going to build through programs that we're going to do to make all of this happen. So we think about the programs we have coming up in terms of social determinants of health that we're building on, a foundation that we've laid now and building for the next 5 years. Things like our OBO, or Infant Wellness Program, our Ohio Better Birth Outcomes Group, which is really focused on infant mortality and growing a focus in maternal morbidity and mortality, addressing the long-standing health equity issue in infant mortality, where even today in our county, African American babies die 3 times more often than white babies. And doing programming across the entire healthcare system in our county to close that gap. Thinking about screening and referral and support, how do we identify people's needs where they are? If it's in the school, if it's in the Health Head Start, if it's in a community center, how do we create stronger screening, referral, and support systems? And particularly, one of our areas where we're going to be doing that is in southeastern and rural Ohio, building on a lot of what we've learned in Columbus and really reaching out to engaging the communities to do those in our rural communities that don't always have as much resource as easily available. Thinking about taking our Healthy Neighborhoods program that we've been doing such a great job on the South Side, and expanding that into the Linden community, another high need community in the Columbus area. So we're thinking about rural needs and thinking about urban needs at the same time. Thinking about school-based health, which is both urban and rural, because all the kids go to school, and it's a great place to engage them in care. And then one special population that we're thinking about in our social determinants and our social justice framework is children who have been exposed to the justice system, children who have incarcerated parents. That's a special kind of risk exposure. It impacts their socioeconomic well-being, their housing situation, their social support networks. How do we do a better job of recognizing those youth and getting them linked to the services that they need so that we can address small problems before they become big problems in their health?
That's a great segue into David, which is leading into our population health. David, you've had a pretty busy year launching the new pavilion. Your team is doing amazing work. Where does this strategic plan take behavioral health in the next 5 years? And how does it integrate into the rest of the hospital's work?
So thanks, Patty. We really have a tremendous need in behavioral health, and NCH has made a transformational investment in this area. And we really have the opportunity to define what the nation's best integrated behavioral health system should be. Thinking about it as different levels of care that need to work together. So all the way from our most intensive services, inpatient and crisis services, to community care, work with schools, work with and prevention, and working with primary care providers. And really getting that to expand those services, partner with the community, and have a more collaborative system. We're also looking to improve or deepen our excellence in individual patient experience and outcomes through a number of ways. One is through improving our capabilities and efficiency with our intake process, actually linking with some state opportunities to do mobile crisis and outreach as well to get to kids right in their homes in the community. And then thinking about applying technology in aspects of what we call measurement-based care. So we have a better idea about whether kids are getting better or not, and being able to then change their treatment
So
plan.
like Dino, you're focused on outcomes, getting to
Yes.
the best outcomes.
Exactly. And part of the way to help with that is actually looking at better ways to diagnose and treat, and that's by really expanding and deepening and establishing leading research programs. And then, to be able to do this tremendous work, we need to be able to expand the provider pipeline and train the next generation of providers, and also to continue to train and give tools to the folks that are treating these kids now. So when we look at our behavioral health research, we get to build on some tremendous areas that we have already, including our Center for Biobehavioral Health, which focuses on brain behavior research and neurodevelopmental outcomes from chronic illness and stress. Very much looking forward to continuing and expanding our partnership with the Institute for Genomic Medicine and how we can apply genomics to behavioral health conditions. Our Center for Suicide Prevention and Research is doing cutting-edge work in looking at the epidemiology, identification, diagnosis, and treatment of kids with youth suicide. And then really expanding an area of that we can have more impact, which is looking at clinical mental health conditions and autism, and can we learn more about how to better diagnose and treat those kids.
Thanks, David. You mentioned your work with genomics. I'm going to pivot now to Dr. Elaine Martis, who's going to talk to us about the genomics work that she's doing. Elaine, genomics is complicated. Could you start with just giving us a small reminder of how it works?
Sure can. So if we take a look at this slide, what you can see is along the top of the slide, just ones and zeros. That's a binary code that makes our computers or our cell phones work. And genomics is really the instruction set that makes our bodies work. And so it's a little bit of a different code, not ones and zeros. It's ACs, Gs, and Ts, as you can see below that line. Really, this simple four-letter code makes us into the people that we are. It is often thought to be a bit dynamic. Over time, it can change, and we really want to study the genomes of patients from different service lines in the hospital in clinical translational protocols to help understand better what causes them to have the problems that they're experiencing. Here's just a simple example on the bottom part of the slide. When we study patients with cancer, which we've been doing since 2018, over 300 patients in our hospital now sequenced using genomic approaches. Oftentimes what we can see when we compare their normal DNA, like from blood cells, to their cancer DNA is illustrated here, where just a single change of a nucleotide, a G from the normal, turns into a C in the tumor. This is now identifying a drug target. There may be a therapy that's FDA approved that we can then use for that child's cancer care. So this is just one simple example of how we study the genome as a form of diagnosis and also interpreting to therapies. On the next slide, what you'll see is that over the next 5 years in the strategic plan that directly interfaces with many of the different service lines in the hospital, we have plans to develop additional genomic programs to really study how DNA changes in these patients. We really want to use this to advance precision medicine, so better diagnosis, better treatment, a better understanding of what the genomic underpinnings are. And to do this, on the third point, we really have to have very advanced computational genomics, infrastructure, and informatics, including large databases that come from population scale studies of specific diseases to really interpret and understand these data. I can just finally illustrate this on the last slide, which shows how we develop our novel genomics research. You can see these 4 quarters, starting with the lower yellow quarter on the left-hand side. We're conducting this patient-facing translational research to develop new research questions and diagnoses. We move that into model systems like mouse or zebrafish models to study these genetic mutations. In this example, we're looking at craniofacial development anomalies. And then we interpret the data that we get from our model systems in light of other genetics information, for example, as well as clinical data to drive new discoveries and understand how those genes, when mutated, really can determine craniofacial anomalies. Finally, we make the endpoint of the virtuous cycle here of research coming back to the clinical impact on patient care, really enabling us, as David just said earlier, to better diagnose and to better treat our patients. And this, as I mentioned, over the next 5 years will encompass multiple other service lines and may spin out additional therapies or new tools for really understanding genetic diseases better.
So let's understand that a little bit more. In 5 years, what does success look like? How will the IGM, Institute for Genomic Medicine, be interacting with behavioral health?
So behavioral health, as David knows, we've already started working on a clinical translational protocol, enrolling patients and families being studied in behavioral health around different diagnoses: bipolar disease, depression leading to suicidality, and also autism. And what we do with these families is really study mom, dad, kids, affected and unaffected, as well as grandparents in some cases, really starting to collect the family's history of depression, suicidality, for example, and really starting to look at how the genome is shared and different between those individuals in that family structure.
David, how would that affect it from your angle?
Well, right now, it's very hard to predict whether a child who might be at high genetic risk for an illness is actually going to develop it. And we would like to be able to intervene perhaps before they even start showing symptoms. And that's where being able to identify genetic markers may really help us to prevent kids from even having these problems in the future.
What about Elaine? How would that interface with Dina's world?
So Dina mentioned a number of really important programs. One I thought I'd just focus on briefly is the toxic stress that's associated with children who interface with the justice system, for example, who have parents that are incarcerated. We can measure through a variety of means using genomics the impact of that toxic stress on the immune system and on the inflammatory response that really leads to poorer quality health for these children. And as Dina mentioned, part of the plan is to be able to measure the impact of what they're doing. And so this is one sort of metric or quantitative way that we could evaluate these children in a relatively benign, non-painful way, just studying a little bit of blood or saliva, to really understand what's going on in their immune systems and indeed how that may be changing over time, hopefully for the better in terms of the programs that they're rolling out.
Then, Dina, what would you do with that information?
You know, that information would be so important because it would help us to have a whole child vision of what's the impacts of these experiences and exposures are. It's easy to see sort of the tip of the iceberg with the loss of family support or the loss of income and those things, but there's a lot going on under the hood. And that genetic information, that inflammation information would allow us to look at the whole picture of the impacts on children.
I think that is so exciting. If you think about the strategic plan and this ecosystem, it is the bringing together of behavioral health, of equity and population health, and of genomics into our own secret sauce that is going to help nationwide children's lead in best outcomes. And with that in mind, we're now going to talk about the foundational elements.